Physiologic implications of appropriate resuscitation. Clinical evidence has demonstrated that maintaining proper patient fluid administration during surgery can help minimize recovery time and improve outcomes long after the patient leaves the operating room. This graphic describes the concept of an optimal resuscitation range, and that exceeding or falling short of this range may result in increased morbidity. The use of goal-directed protocols using flow-based or affected parameters such as cardiac output, oxygen delivery, or venous oximetry can assure the adequacy of resuscitation. Multiple organ systems are affected by the adequacy of resuscitation. The gastrointestinal tract, for example, is greatly affected by over or under resuscitation. When properly hydrated, gastrointestinal tissues are well perfused and receive adequate oxygen delivery, ensuring good bowel function. This is especially important when recovering from GI surgery. However, if the patient is over-resuscitated with fluid, the GI tract is at risk of becoming edematous. This swollen tissue opens the possibility of stress to the suture line and the potential for anastomotic leaks. Under-resuscitating a patient runs the risk of inadequate cardiac output or hypoperfusion. A hypoperfused bowel may encounter immotility and an ileus formation. In addition, hypoperfusion raises the risk of tissue breakdown and anastomotic leaks at the suture line. The kidneys are especially sensitive to over or under resuscitation. When functioning normally, kidneys cleanse the blood of impurities while encouraging healthy urine output. Hypoperfusion can lead to a decreased blood flow or hypovolemia, as indicated by decreased urine output and increased concentration of urine. This can lead to renal ischemia and acute kidney injury. Conversely, a positive fluid balance can elevate venous pressures affecting outflow, increased intracapsular pressure, and subsequently decrease renal blood flow and GFR. Renal injury caused by over or under resuscitation may be temporary or permanent, sometimes requiring pharmaceutical support or even dialysis. If permanent injury occurs, this will significantly compromise quality of life and cost of care, while increasing risks of complications. In the respiratory system, the lungs' ability to oxygenate blood is critical to overall oxygen delivery to the tissues and resulting organ function. Normal diffusion of oxygen through the alveolar capillary membrane, where it binds with red blood cells for transportation throughout the body, is the key to proper arterial oxygenation. Although occurring less often, significant over-resuscitation of fluids can profoundly affect the lungs' ability to oxygenate blood. Airways swell. Fluid fills the alveoli, and the alveolar membrane thickens, impeding oxygen's ability to diffuse into the bloodstream and bind with hemoglobin. Over-resuscitation results in compromised oxygen delivery to the tissues, potential increased need for therapeutic oxygen, and possibly increased time on mechanical ventilation. Traditional vital signs and right heart pressures are poor indicators of the patient's fluid responsiveness. In fact, 50% of patients given fluids do not show an increase in stroke volume, leaving the clinician at risk for over or under resuscitating their patient. Dynamic indicators, such as stroke volume variation, or delta changes in stroke volume with fluid challenges or passive leg raising, help assure the appropriateness of volume therapy, mitigating the risks associated with inappropriate or unnecessary interventions.